All right. Hey, everybody. I'll be talking with you today um, about my dissertation entitled Examining the Characteristics that Support Nurses' Innovative Behaviors. This dissertation is dedicated to my family, friends, and colleagues who have supported me in multiple ways during this 5-year process, especially my wife, Lara, and my sister, Jen, from whom I literally would not have been able to do this without, as well as my mom and my daughter. I'd also like to thank and acknowledge my dissertation committee and readers for their help and guidance, as well as Dr. Kelly Richmond and Dean Toney for their unwavering support of nurse-led innovation and the innovation work we push forward at Penn Nursing. Finally, I'd like to acknowledge and thank the nurses who participated in this survey and all the nurses the world over who are innovating every day. I have some disclosures. I'm on 3 grants related to the use of the innovative behaviors of human-centered design and design thinking in nursing. All right, as we know, globally, nurses are central to advancing patient care, improving outcomes, and filling critical gaps in processes and services. Healthcare organizations that focus on innovation have been shown not only to improve the health and safety of patients, but had greater engagement of their employees and were able to solve workforce challenges. Therefore, fostering innovative behaviors by nurses is a critical component to improving healthcare and sustaining the nursing workforce. Incorporating innovative behaviors such as human-centered design and design thinking into the profession of nursing is relatively new, though, with most literature dating back just 10 to 15 years. In the last 5 years, we've seen a groundswell of support encouraging individual and organizations to consider incorporating innovative thinking and behaviors into education and practice. But not every nurse has the ability to be innovative, and determining what combination of individual and organizational characteristics enhances a nurse's innovativeness will be key to educating the next generation of nurses as innovators and supporting and empowering innovative behaviors in practice. Before I move on, I'd like to clarify some terms as they relate to this dissertation. Innovation is defined as a new idea, method, or device. Innovative is the introduction of original ideas, and innovativeness is an awareness of and willingness to innovate. Innovation, therefore, occurs through a deliberate process of innovative behaviors similar to design thinking, which is a 5-step rigorous approach of creative problem solving where an individual understands and defines a problem through empathy, generates new ideas and solutions, and produces a prototype to test with end users. There are limited studies within nursing examining innovativeness and associated innovative behaviors. 2 previous studies examined the innovativeness of nurse leaders using the validated survey tool, the scales for the measurement of innovativeness. This is the same scale that I used for papers 2 and 3 of this dissertation. They found that 5% and 1.5% of nurse leaders surveyed were classified as innovators according to the diffusion of innovation theory. However, there's still a lack of data regarding what factors contribute specifically to the innovativeness of nurses and whether nurses are inherently innovative or if it is a behavior that can be developed. Therefore, the purpose of this 3-paper dissertation focused on examining the characteristics that support nurses' innovativeness by understanding the individual and organizational characteristics of nurses engaging in innovative behaviors. The synthesized results from paper 1 laid the groundwork for papers 2 and 3. As a note, today I will only be highlighting and summarizing the main findings from my dissertation, though there's much more detail in the paper if you are so inclined. The current proposal is informed by 2 conceptual models, the individual innovation in the workplace model and the diffusion of innovation theory. The individual innovation in the workplace model proposes that innovative behaviors are directly affected by 4 different yet interrelated systems: individual attributes, leadership, work groups, and climate. This dissertation focused mostly on individual and organizational attributes. The main theory being used as a foundation for this study, though, is the diffusion of innovation theory. This theory details the patterns and rates of adoption of innovation and identifies a series of associated characteristics, stages, and behaviors. These characteristics, which are normally distributed, as you can see here, identify where individuals sit in respect to the theory's adopter categories of innovator, early adopter, early majority, late majority, and laggards. I will begin with paper 1. For paper 1, we sought to understand the landscape and utilization of human-centered design and design thinking for the creation of health interventions. We performed an integrated review focused on how human-centered design and design thinking were being used, and then synthesized the literature based on the approach or methodology, along with the characteristics of the articles, phases of design thinking included, and if the article was nurse-led. 4 research databases were searched from inception through November 6, 2020. Search terms included design thinking, human-centered design, society-centered design, equity-centered design, and nursing or nurses. Articles were included in the review if they were written in English, published between January 1st, 2016 through November 6, 2020, and focused on human-centered design and design thinking in healthcare. To focus on a unified health system, any article that did not occur in the US was excluded. A total of 293 publications were retrieved from the database searches. After deduplication, 142 unique manuscripts were reviewed, and after review, 24 articles were included. Of the 24 articles included in the final analysis, just 6 or 25% were nurse-led. When analyzing the articles by approach or methodology, 50% stated they were using human-centered design, 21% design thinking, and 29% stated using both human-centered design and design thinking. Overall, just 42% included all phases of the design thinking methodology in their process. Paper 1 was published last year in the journal Nursing Forum. We concluded that there are inconsistencies regarding who uses design thinking in their practice, and specifically, nurses were less likely to be lead authors on these papers. Whether that finding suggests nurses are not engaging in those innovative behaviors or just not publishing their results is unknown. The review also didn't clarify whether the likelihood of designing and testing interventions informed by human-centered design and design thinking were more likely based on individual traits, such as willingness to innovate, or contextual characteristics such as greater organizational investment and innovation. This is an important consideration as it guided papers 2 and 3. For papers 2 and 3, the methods were similar and the data collected were used for both studies. The main survey tool for papers 2 and 3 was the established tool, the Scales for the Measurement of Innovativeness, developed to estimate the personality characteristic of innovativeness and measure willingness to change. It is a 20-question, 7-point Likert scale survey with a maximum score of 140. A higher score is associated with a higher degree of innovativeness. A purposive sampling of nurses who engaged in innovative behaviors in the past 3 years and who are licensed and working in the US occurred through outreach to individual nurses, nursing organizations, and nursing innovation-focused programs. Posts were also created on social media and the snowballing technique was used. Recruitment took place over 6 weeks. Between December 12th, 2022 and January 22nd, 2023, 662 survey responses were received. Of those, 305 began the screening survey but did not complete it. After reviewing the remaining responses, 329 surveys were kept in for analysis. Now I will talk about the specific aims for findings for paper 2. The purpose of this study was to examine the innovativeness of nurses in the US who showed interest in innovation by engaging in activities that encourage innovative behaviors. And there were multiple aims of this study. First, we sought to validate the Scales for the Measurement of Innovativeness tool in our sample of nurses. Second, we sought to measure our participants' innovativeness using the Scales for the Measurement of Innovativeness tool and examine their associated individual and organizational characteristics. Based on these results, we compared those who self-identified as an innovator versus those who did not in order to show similarities and differences. Finally, we performed an exploratory factor analysis of the scales for the measurement of innovativeness tool to determine the correlates of innovative behaviors. For paper 2, participants' innovative behaviors, individual, sociodemographic, and organizational data were analyzed using descriptive and inferential analysis. In order to validate the scales for the measurement of innovativeness tool, we performed psychometric testing on the original 20 items. We used face validity to assess respondents' perception that the test appropriately measured the innovativeness and performed the Chromebox alpha for reliability. Additionally, we performed an exploratory factor analysis using baromax rotation to confirm the construct validity of the tool. The full details of the methods and the analysis are in the text of the dissertation. Overall, of the 329 respondents who completed the survey, the mean age was 47 years. The majority were white, non-Hispanic, or Latino females. In the last year, most respondents participated in 1 to 3 innovation events. Few of the respondents' institutions offered human-centered design or design thinking, education, lectures, resources, or workshops. However, many of the respondents' institutions offered education, lectures, resources, and workshops specific to innovation. The scales for the measurement of innovativeness tool was found to be reliable in our population with a Chromebox alpha of 0.847, and the mean innovativeness score of our sample was 120 out of 140. A higher innovativeness score was associated with whether respondents' institutions offered human-centered design or design thinking education, lectures, resources, and workshops, as well as innovation lectures and workshops. We also found that the more innovation events a respondent participated in, the higher their innovativeness score. Of the 329 respondents who completed the survey, 87% viewed themselves as an innovator. When we compared this group, there was no statistically significant difference in the demographic data with those who did not view themselves as an innovator. However, the mean innovativeness score was higher for those who self-identified as an innovator compared with those who did not. Using the questions and mean scores from the scales for the measurement of innovativeness survey, the exploratory factor analysis determined 4 factors as seen here. Factor 1, risk aversion. Factor 2, willingness to try new things. Factor 3, creativity and originality. And factor 4, being challenged. We feel confident in factors 1 through 3, but factor 4 included 2 questions that respondents commented on most in the face validity section, noting that they could be interpreted as either a positive or negative trait. Therefore, it is possible that many of the respondents interpreted those questions differently. For this survey, though, the questions were scored as a positive, where a higher score meant that the participants found being challenged as a positive trait. Future work should examine this factor further. We then examined the association between our 4 factors and the individual and organizational characteristics of the respondents to determine the correlates of innovative behaviors. The biggest takeaway from this slide is that support of, exposure to, attendance at, and offerings of innovation, as well as human-centered design and design thinking activities, were associated with each of these factors. For example, for factor 2, willingness to try new things, we saw a positive association with how many innovation events the respondents participated in over the last year, with the offering of innovation and human-centered design and design thinking activities by an organization, as well as with support of innovative thinking by nurses. In contrast, a decrease in exposure to offering of and attendance at these events was associated with factor 1, risk aversion. The study showed that there are multiple individual and organizational characteristics associated with the innovativeness of nurses, but especially important are the characteristics listed here. Finally, I will talk about paper 3. So for aim 1 of paper 3, we used the data from paper 2 and compared the results of the scales for the measurement of innovativeness survey to determine the concordance of our sample of nurses engaging in innovative behaviors with the diffusion of innovation adapter categories. We then performed a latent class analysis in order to examine the individual and organizational characteristics of our sample and group them based on patterns. In our exploratory aim, we sought to determine if we could create a new typology of nurses engaging in innovative behaviors. Using the exploratory factor analysis from paper 2 and the latent class groupings, along with the nurses' individual and organizational characteristics, we created a taxonomy and phenotype of nurse innovators. Similar to paper 2, for paper 3, participants' innovative behaviors, individual, socio-demographic, and organizational data were analyzed using descriptive and inferential analysis. In addition, as mentioned, we performed a latent class analysis using the exploratory factor analysis data from paper 2. We used the results from these analyses to create our taxonomy and phenotype. Again, the full details of the methods and the analysis are in the dissertation text. The diffusion of innovation theory adapter categories and where they fall in the normal distribution, along with their associated behavioral characteristics, are listed here. For paper 2, the total innovativeness score ranged from 0 to 140. For this study, we matched the innovativeness scores from the scale for the measurement of innovativeness survey with the diffusion of innovation theory adapter categories. As you can see here, the innovativeness scores range from 0 to 22 for laggards, 23 to 69 for late majority, 70 to 117 for early majority, 118 to 136 for early adopter, and 137 to 140 for innovators. As noted, 329 nurses engaging in innovative behaviors were included in our study. Of those, 9 had an innovativeness score representing an innovator, 201 of early adopter, 117 for early majority, 2 for late majority, and none had a score representing laggards. The mean innovativeness scores for the scale for the measurement of innovativeness results based on the diffusion of innovation adopter categories are listed here. There were only 2 respondents who classified as late majority, and only 1 completed some of the survey questions, and we had no laggards in our sample. Therefore, these groups are not included in the analysis, though their data are included in the tables and subsequent figure for reference. There was a statistically significant difference in the innovativeness scores between adopter categories, with those who were categorized as an innovator having a higher innovativeness score compared with the other 2 adopter categories included in the analysis. As you can see from the figure, our sample of nurses engaging in innovative behaviors, which are the bars in orange, had a similar percentage of innovators and early majority compared with the diffusion of innovation theory adopter categories, which are the bars in blue, but significantly more early adopters and much less late majority. Again, we had no laggards in our sample. The diffusion of innovation theory adopter categories is just one way to group respondents based on their innovativeness, but we wanted to see if we could create a different grouping. Therefore, we sought to create our own taxonomy using the latent class analysis results, which incorporated our exploratory factor analysis data. The latent class analysis determined 4 distinct classes from our sample. Class 1, which we classified as non-innovator, Class 2 as uncreative, Class 3 as optimal innovator, and Class 4 as wary innovator. As you can see here, Class 3 contained the vast majority of our sample. The taxonomy, therefore, included our 4 latent class analysis groups, and I'll highlight Class 3 as, again, this was the group that included the majority of our respondents and is our optimal innovator class. Class 3's taxonomy included average risk aversion, average willingness to try new things, average creativity and originality, and average being challenged within our sample of nurses engaging in innovative behaviors. We then wanted to see if we could use the innovativeness scores as well as the individual and organizational characteristics to create a phenotype of a nurse innovator based on the latent class analysis results. For our phenotype, we determined the statistically significant characteristics from our data for each class. For all bivariate analysis, class 1 was removed due to a small sample size of 2. There were no differences in the sociodemographic characteristics between the other classes. For our 2 innovator classes, class 3 optimal innovator and class 4 wary innovator, both included high innovativeness scores, greater exposure to human-centered design and design thinking activities, and willingness to innovate. All innovators, as determined by the diffusion of innovation adopter category results, were included in class 3 optimal innovator. Our study showed that there are individual characteristics associated with the phenotype of a nurse innovator, specifically the high innovativeness scores, exposure to human-centered design and design thinking activities, and willingness to innovate. The taxonomy of nurses engaging in innovative behaviors included 4 groups, 2 of which we classified as innovators. Our findings suggest that if we want nurses who are comfortable with trying new things and being creative, we need to focus on the attributes of nurses in classes 3 and 4, as these are the groups that have the most likelihood of innovating. There are several limitations to this dissertation. A major limitation of this work is that it only examined nurses in the US who are engaging in innovative behaviors. This population may not be representative of all nurses in the US or those outside the US, and specifically could be different than nurses not engaging in innovative behaviors. Additionally, it did not account for the nurses who are innovating in their practice, but may not have engaged in innovative behaviors such as workshops, lectures, or other activities. Therefore, selection bias may have occurred as we only included nurses who were engaging in innovative behaviors. From our results, we've determined 3 distinct areas for future work. First, for schools of nursing, infusing innovation education throughout the entire curriculum, as well as offering and encouraging active learning activities that foster the correlates of innovative behavior should be considered. For health systems, using our results as a roadmap, they should begin to cultivate and encourage a culture of innovation that establishes innovation programs that support risk-taking and creativity in an evidence-based safe environment. For future research, there are many areas that could be explored further. For example, the study only looked at willingness to innovate. However, to truly understand how nurses are innovating in practice, we need to examine actual implementation of innovation by nurses. Prior to our work, an individual's innovativeness was said to be made up of 2 components. The first are the characteristics and traits that one possesses, and the second are the skills or behaviors that can be taught, such as through human-centered design and design thinking. Our studies determined that a third component is also important: support and encouragement from an individual's organization. Healthcare systems and their workforces are changing dramatically. Therefore, having nurses, nursing organizations, and nurse leaders who are adept at being innovative will be key to securing equitable health and healthcare systems of the future. This requires an understanding of the individual and organizational characteristics that support and encourage the innovativeness of nurses in order to be able to establish criteria and nursing curricula that foster these skills and assist and empower them in practice. This 3-paper dissertation hopefully sets the foundation for these understandings. I'm happy to take questions. Thank you all for listening.
Thanks, Marion. I'm going to go ahead and ask the committee first for their questions before we entertain any questions from the audience. Committee members, if you could unmute your video. I know that, there we are. Okay, so who wants to go first? Any questions for Marion from the committee? Maybe we'll start with the readers to kind of go in a stratified approach. Pam, Margot, any questions? I think Pam's trying to unmute. Oh wait, I have to unmute you now because we were getting Zoom bombed. I'm so sorry. I totally forgot. All right. Pam, do you want to go?
Thank you. Oh my gosh. Thank you so much. It's so funny to have technological problems on something about innovation. It just kills me. But anyway, wonderful presentation, Marion. Thank you very much for your work in this area. I think it's so timely. It really, your initial review showed that this is really an up and coming area and you're right on the cusp. And I'm just really excited to see where you're going to take this. I had a couple questions. Let me find my notes here. So I am kind of curious about what you think about the limitations of the measurement of innovativeness scale, because, that challenged question was really interesting. The qualitative comments on that were very, I think, pertinent to the fact that there were only 2 items on that actually fell into the challenged category. So I wanted to know if you had any comments on that. And I'll let you answer that.
Okay.
A couple other.
Sure. So great question. Thank you, Pam. I have a slide regarding the measurement tool. So let me pull this up. All right, can you see that?
Yes.
Okay, great. So, there were,
okay.
So this was a validated scale. It was used in 2 other nurse-focused studies. And the reason that I really wanted to use it is because it did focus on the diffusion of innovation theory. And did I lose you all? Are you all still there?
Yeah,
we're there. We're here. Your slide went small. There you go.
There we go.
Okay, sorry. Yeah, so that was a problem that we did see in the comments for the face validity, was that the question about being challenged came up numerous times. However, that was one of the areas where we knew that the focus was going to be on the other questions, because there were more of the questions in the exploratory factor analysis factors that were much more robust. So it is something we want to look at further. And it is something that knowing it now, would want to change in a future study, being able to clarify from that face validity in the open comments the differences between why some people think about it as being challenged as a positive versus a negative. I think there's a lot there that we could explore with that. And so I think that would be a great focus for another study.
Great. I do like how many other studies you have the possibility for from this. Like just in the written dissertation, there were just many options for that. And then, so how do you feel like the purposive sampling had an impact on your diffusion of innovation categories?
Well, so yeah, great question again. So we knew that we weren't going to have many laggards or late majority. I mean, that makes sense. We're actively engaging nurses who are being innovative. So that, again, made sense that we had almost no one in those categories. I think it is really interesting that we had a majority of people in the early adopter category, which is important because you need early adopters to push out new innovations. It's great to have nurses who are coming up with new ideas and innovating, but in order to get others to use those new innovations, you need that diffusion of innovation, and the category of people who do that are the early adopters. So I think that was a really interesting finding, that we had so many nurses who were categorized as early adopters, as opposed to innovators. But it makes sense. You need those people in healthcare pushing out new ideas.
Great. I have one more question and then I'll let Margot go, if that's okay. Because I just really enjoyed reading your dissertation. It was really great. The presentation was really wonderful too. I was kind of curious about, and maybe I just didn't understand the latent class analysis, but I was really curious how those scores for innovator and early adopter were decided, because the innovator was so narrow. The range was, so narrow from like 140 to 137 or something like that. Like it would be really hard to get as an innovator. So I was kind of curious how you came up with the numbers for those categories and if that really influenced how many early adopters you had.
Yes, great question. And that's based solely on the diffusion innovation theory and the different breakdowns of each of those in the normal distribution. So the way that we did it, and again, I have a slide on this that I can share, but maybe I'll just talk you through it. So the innovativeness scale ran from 0 to 140. We had 20 questions on the innovativeness survey, so that gave us a total of 140. We then created the range based on the diffusion of innovation theory adopter categories normal distribution. So 2.5% of that gave us a range of 137 to 140, which was innovators, and so on and so forth. Do you want the visual, Pam, or does that answer your question?
No, I think that makes more sense to me. So you did it based on what the percentages would have been based on the diffusion of innovation, not on
exactly.
See, somehow I thought the latent class analysis had guided you. I just couldn't quite understand how those data became. So that was really helpful. Thank you.
Yes, and that
I'll pass it off to Margot.
And I'll just say that was similar to how one of the other studies that use the scales for the measurement of innovativeness in the nurse leaders, that's how they classified it as well. So I reached out to them, asked them how they did it, and then used their methodology.
Great. Thank you. Great job.
Great job, Marion. Wonderful presentation. I have a question about sampling. I think that kind of dovetails on Pam's regarding your responders. And so it was interesting to me to see, I think 42% of your respondents worked in Magnet. Did I read that correctly?
It is possible. Give me 1 second. I can look.
And the reason I asked that, or it stood out to me because so few hospitals in the US are actually magnet status. So I wondered, given the, pretty high representation among your respondents who were working in magnet, and given the relationship between organizational support and innovativeness, how might your findings kind of generalize to settings that aren't as robust as those that are magnet?
Yeah, that's a great question, Margot. And I think if I was going to do this study again, that would be one of the other places that I'd want to focus on. Most of the respondents in our sample actually didn't work in weren't clinicians.
That was my next thought. I was like, such a small percent were staff nurses. And so that was literally my next question, Marion.
So, it really depends. A lot of people put NA for the magnet status question. So I don't even know, honestly, how reliable that number is in terms of if that's a higher proportion of magnet status, then it should be, because so few of our respondents were clinicians working in a hospital setting. Okay. So if I were to do this again, I'd want to focus solely on nurses working in the clinical setting, to see if they were, see what their innovativeness is. Because a lot of our sample were nurses who are working in startups or nurses who are working in academia and doing innovative things or running organizations. So it was a very different sample than just clinicians working at the bedside.
I think I keyed in on that because your implications are really speaking to what health organizations can do to inspire innovation among their nurses. But I was like, wow, only such a small percent of the respondents were staff nurses or clinicians. And I think that, one could pick up on that because so many of your implications are for healthcare organizations to inspire nurses, which I think is what your end goal is to inspire, not just nurses who are working at the bedside, nurses broadly, but certainly nurses who are working at the bedside. So I thought that was something to kind of think about when such a small proportion of the sample are actually working in clinical practice.
Yeah, I totally agree. And I was actually really surprised with the small number of nurses working clinically. That definitely could have been, sample bias with how, we pushed this out both on social media, but then to the different organizations that I sent this to.
Mm-hmm. Okay, so I thought that it could certainly affect kind of the generalizability, but also you have a lot of implications for other studies. And so that might be one to think about, how do we really kind of hone in on kind of diverse clinical settings and on kind of direct care providers more specifically. And I guess the second question is about your implications to move innovation into curricula, nursing curricula. And so what do you make of your findings about faculty members and researchers? So about a fifth of your sample was faculty members and researchers, and they kind of are falling largely in your, mostly, I think, kind of the early adopters and early majority. So talk a little bit about, knowing what you know about this particular sample and trying to move them to get innovation into their curriculum. Like what do you think about what you learned and kind of the likelihood or the ease of them being able to be motivated to move human-centered design and other innovative kind of options into the curriculum?
Yeah, I think, again, I think organizations and individuals are starting to see the power that some of these innovative behaviors can have, not only for education, but practice. And the more that we, I say this all the time, the more that we expose our students to innovation, the more that they will go out and innovate. And that's really what we saw in these findings, like exposure to offerings of and attendance at these events led to higher innovativeness and a variety of other things. And so having a lot of faculty and researchers who took this survey and were engaged in these behaviors is a good sign that they understand the importance of this and then can translate that into the work that they're doing in academia. And so, I hope that some of those future implications will help to have other institutions start infusing these things into their classrooms. And there's lots of easy ways to do that. And I could go into a number of them if you wanted me to, but I think this shows that there is a place to start.
Thank you. I'm happy to. I thought that was kind of the bottom line implication, and just wanted to kind of hear you flesh it out. So thank you. Great job.
Let me ask the committee members if they have any questions they wish to ask. George, Subhash.
Sure. Marion, great job. I wanted to follow up on the question around education that Margot mentioned and how your findings could inform, curricular initiatives. Recognizing that not everybody may want to or should perhaps be an innovator, how do you think educational efforts need to address the fact that we need to foster innovation, but also recognize that that's not necessarily a trait that needs to be, or maybe you think it needs to be for everybody. So I guess, what are your thoughts about that?
Well, I think a lot of things. I definitely think that there are ways to infuse this into nursing curriculum that exposes all students to it, but doesn't necessarily mean that every student who graduates is going to go out and be a nurse innovator. And I don't think, again, from our findings, that we need that. We need the small group of nurses who are innovating, and then we need that other group of nurses who buys in, or early adopters, and pushes and diffuses those innovations. But I do think it's important to expose students to this, because if they aren't exposed to it, they won't know about it. They won't know then what that means for healthcare. In nursing curricula, we get exposed to all sorts of things, and not every nurse is going to go into critical care. Not every nurse is going to go into pediatrics, but that doesn't mean we shouldn't be exposed to it and at least learn about it. And I think all students should be learning about human-centered design and design thinking and other innovative methodologies in their practice in some way. Exposure, again, could lead to more nurses innovating in the future. So I do think it's important. I do think all students should be exposed to it at some level.
And maybe a follow-up question to that. Obviously, there's some intrinsic traits that make somebody be inclined to embrace innovation more, but there's also some systemic factors that can become barriers or facilitators for innovation. And based on your work so far, as well as any future work, how do you think, even if we have the educational initiatives in place to motivate and encourage every individual to become an innovator, or at least get exposed to innovation, from an organizational perspective, what are your thoughts around, based on your study findings, what could organizations do to lift some of those barriers, or motivate their clinicians or nurses or others to embrace innovation?
Yeah, I have so many thoughts on this. I think there's a number of things. I mean, the easiest things are just to offer different workshops or lectures around human-centered design and design thinking. What we saw was many of the institutions offered innovation-specific education lectures and resources, but not many offered human-centered design and design thinking workshops, educations, lectures. I'd love to parse that out more and understand what people think innovation is versus human-centered design and design thinking, and why some are being offered and some aren't. I know that wasn't your question, but I think there's a lot to figure out there. But I do think organizations could start by just offering, 1-hour lectures about these different topics, or workshops for their clinicians, or begin to start using, we have in hospitals quality improvement activities that they do to improve certain problems that they're seeing. They could start infusing the human-centered design methodology into that type of work. Additionally, I think, hospitals really need to allow nurses time away from the bedside to be able to engage in these types of activities, instead of restricting them from participating in these types of activities, really supporting, encouraging, and allowing them to do that. So there's a lot going on with nurse burnout and the nursing workforce, and I think there's an opportunity here to understand that in the long term, encouraging nurses and to participate in these types of things will benefit their institution.
Subhash?
Hi, Marion. I enjoyed listening to you today. I always feel like, okay, why can't I be calm like that when I'm doing a presentation? So excellent job. So,
thank you.
My question is, like, in your limitations, right? You identified selection bias as one of the limitations of the study. So if you were going to do this study today, given that what you have learned, what would you do differently? Could you share with us in terms of like reducing the selection bias, or going forward in the future study, you do it a little bit differently such that the results become more generalizable?
Yeah, I mean, I would really like to open this up to all nurses, specifically clinicians, but not just those engaging in innovative behaviors, but really any nurse working in the clinical setting, and working with, instead of innovation-focused organizations, really working with health systems to help push this out so we can get a more representative sample of nurses who are practicing clinically to understand their innovativeness, as opposed to just nurses engaging in innovative behaviors who might not necessarily even be working in a clinical setting.
And one other question I have is like, when I was looking at the breakdown, right, what 76% of the participants were identified as white Caucasian. So in terms of like, is that the general mix of racial breakdown in a sense by different categories in the general nursing profession, or what would you do if it's not, like, such that there is more representation of other people?
Yeah, our sample actually was more diverse than the nursing profession. So nursing is 91% female and 81% white, and we had 87% female and 77% white. So slightly more diverse than the nursing profession, but for sure, nursing and innovation needs to think about how to be more inclusive and representative of all nurses in the profession, not just white women who are the majority in this profession. That's a reckoning the whole profession has to have, though. I'm happy to help push that.
Yeah, that's all the questions that I had, and I enjoyed working with you on your dissertation and listening to you today. So good job.
Thank you. I just want to say again, I could not have done this without each and every one of you, and I really appreciate from start to finish all of the support, guidance, and help you've all given me individually and as a group. And I really appreciate working with all of you.
Thanks, Marion. We have a little bit of time for questions from the public. You can raise your hand on the feature, or put your, so I can unmute you, or put your question in the chat. Okay, so I'm not seeing any. I'm going to give it one more minute just in case. If not, the committee will. Oh, I see Terry unmuting video. Here we go.
Oh, how can we not have a question from the public? There's so many next steps that you can do, and you probably really articulated this in the in your dissertation. But if you had to say, this is the most important next research study I want to do to move this field forward, what would it be?
So I think it goes back to, I think I mentioned this in the slide, really wanting to understand actual implementation of innovation by nurses in practice, not just willingness to innovate. I mean, this came up in the open comments as well. There's a big difference between wanting to do something or being willing to do something and actually translating that into practice. And that is a very valid point. And I think this is a start of looking at what innovativeness is, but really understanding what innovativeness is in regard to actual implementation, I think would be even better in terms of our understanding of what those skills and qualities are that we need to be honing in education and practice. Thank you for your question, Terry. Hi, Stacy.
Hi, Marion. Thanks so much for this work. I really enjoyed hearing this iteration of it. I'm wondering, as we all know, that teaching, clinical, and research process are kind of triangulated with each other. And you were leading a lot of innovation programming at the School of Nursing and other places while you were writing your dissertation. So I'm wondering what kind of reflections this research had on your teaching practice. I know it went the other way around a lot, like a lot of your teaching and clinical practice inform the research design, but how did you see it go kind of the other way?
Yeah, I mean, I think honestly, it really just confirmed what I say all the time is that, again, if you expose folks to these types of innovative behaviors, they're going to be more willing to do those things in practice. And so as I was starting to get the data that showed that this could potentially be the case, it just heightened me wanting to think about other ways that we can start to include these innovative behaviors into the curriculum, into active learning, and then also in the clinical setting. So working more with hospitals and health systems to think about how they can start infusing these things in practice as well. So it really focused on just confirming what I was saying with no data, now having supporting data to be able to talk about those things even more. Thanks, Stacy.
Any other questions before the committee peels away for a little bit?
I'm happy to entertain while they peel away.
Thanks, Marion. So I'm going to peel the committee away. Committee, you're going to get an invite from me in just a second for a breakout room. There, you should have gotten it. And Marion, I'll pull you in.
Okay.
In a second.
Okay. And Janae, when Jose pulls me in, you'll still be here, correct? In case people have questions. I don't know.
Yeah, I can stay.
Okay, great. If anybody has questions while they're away, I'm happy to answer them. Or just chit chat.
How are you feeling?
Ooh.
Yeah.
Hey, Richard.
Great job.
Thank you all for attending.
So I have a question since your committee is not here.
Sure.
When you think about if you had to design an intervention, would you focus on intervening at the individual nurse level or at the nursing department, healthcare organization level? Where do you think you'd get the biggest bang for the buck, given what you found?
It's a good question. I'm really interested now in just understanding individuals. So I think I'd start at the individual level. Though I do think the bigger bang for the buck would be at the organizational level. So I could see it, I could see doing both, but for different reasons. I mean, there's so much that could be learned in either one. So yeah, I think I could do both.
So good answer. So Marion, I turned your video off because you're sort of breaking up so we don't lose you. It would be interesting to think about designing an intervention and testing an intervention.
Yes, I absolutely agree. I mean, again, you can't see it, but I have a list of next steps to focus on, not just partly from what I learned from this study in terms of the results, but also partly from what I learned just doing this study and where I think it could have been stronger, and things that our respondents brought up in the comments that made a lot of sense, some of which I mentioned already. So yeah, I think there's a lot of places to go. I actually would love to do a longitudinal study of nursing students who've been exposed to these innovative behaviors in their curriculum. Yeah, I have lots of ideas.
You always have lots of ideas, Marion.
I know you won't be surprised by that. Other questions? Richard, you came on. Did you have a question? It was good to see you, by the way.
No, I didn't have a question. I just wanted to say congratulations.
Thank you, Richard. And I gave you a shout out in the paper, but I didn't on here. I couldn't have been able to do paper one without you. So thank you for all your help with that.
You're very welcome. Actually, like previously, I did have a question, but Terry stole my question. What would you do first?
Blame me, Richard.
I'm not blaming anybody. I'm making an observation. It was a very good question, Terry. It was one that I was very interested in hearing the answer to.
Hey, Haley, I think you're on mute, or at least I can't hear you.
How about now?
There you go.
This is really exciting. I really enjoyed listening to this and hearing what you've been working on, and it really started me thinking about sort of the growth mindset versus fixed mindset kind of work, which I'm not really familiar with at all. But I'm really interested in like how many of these things, like creativity and originality, like is that a fixed kind of trait that somebody has, or can you teach that? And I think you spoke a lot to that, but I often feel that and this is a wild generalization, but that nurses I talk to just haven't quite thought of themselves as like creative people in the past. But what if you tell them they are, then it sort of opens up this whole new world.
Yeah, I totally agree with you. And I hear this all the time, both in the classes that I teach or the workshops that I do, or even just at like hackathons and things that I participate in. Nurses generally do not think they are creative. Meanwhile, they are like one of the most wildly creative group I've ever encountered. And so I think what I try and do in the human-centered design class that I teach is to encourage that innovation, that creativity, and let them start to be creative, because it's similar to my thoughts around innovation. If you expose people to it, they'll be more innovative. If you expose them to creativity and what that means to them, not just like in general, then they'll start to be more creative and think of themselves as more creative. But for sure, I agree, people, and especially nurses, often don't think that they're creative. And I hear it all the time. It's just encouraging them to think more about what they're doing as creativity, and then seeing that as a vessel to be more creative.
Yeah. Oh no, go ahead.
No, go ahead.
I was just going to say, from an organizational standpoint, it's like the policies and procedures, I feel like sort of remove that ability to think differently about issues and problems, or at least, not wanting to seem like you're straying from a policy and procedure. Yep. So it's like, how do you navigate those two realities at once, that you want people to be creative and think differently while also, sticking to the policies and procedures that are put in place.
Yeah, and I talk about that a little bit in the dissertation, in terms of like what we saw as risk aversion, or people were more or less creative. Well, we teach nurses not to be creative. We teach nurses not to be, to take risks, because that can oftentimes then lead to not following standard of care, or these like algorithms that we create that, you're right, don't allow for creativity or risk taking. But there are ways to do that in safe environments, within clinical settings, where you can then expose nurses to these things and let them be creative and let them take risks that aren't going to be, during a code in clinical practice. Like, it's not one or the other. And I think part of what I'm trying to get at is to help hospitals and institutions understand that there is a balance here. You can infuse creativity and risk taking in your nurses in a safe, evidence-based way. And it will only help them to think differently and solve problems differently. All righty. Any other questions or comments while we're waiting?
Hi.
Hello.
I think because you're the host, I can't pull you into a breakout room, but you should be able to.
Okay, let me see.
It should say join.
Okay, yes, I will do that. Okay.
All right. We'll be right back, everybody. Hi, everyone. The committee has just finished its deliberations, and we have unanimously decided to recommend a full pass in both the oral defense and the written dissertation to Dr. Marion Leary. So Marion, you may need to change your, rename your Zoom link now that you have completed successfully your dissertation. Congratulations.
Congratulations.
Thank you all. Very much appreciated. Again, couldn't have done it without each and every one of you and all of my family and colleagues. So thanks. Very excited.